put your name and place where you're coming from, so we can identify you. And unfortunately, these are kind of webinars where you're not able to see us, or rather, we are not able to see you or even talk to you. But nevertheless, we have our chairperson moderator who will be your voice. We have Dr. Ravi Shankar, who is a moderator today, and Professor Raghuram, who will be introduced soon. So the questions to be in Q&A box and the chat box. Please go on chatting whatever you like. Please put in your comments and everything. So with these few words, I'll hand it over to Dr. Mahesh. Do you want to say anything? We have Professor R.R. So you want to say anything?
Yes, I thought we should give another 2-3 minutes for people to join in, because it's just 7:30, just to make sure that we begin with people once they've settled down.
Yeah.
Is that okay? We could just start in another 2-3 minutes.
Yeah, we can wait for 5 minutes even, no problem.
It's also on YouTube. Just to let people know that this is also being broadcasted in YouTube.
And when you say it's YouTube, it's live, is it?
Yeah, it is live, sir.
Yes.
Oh, fine, good.
It's a live streaming, right?
Live streaming, and this will also be available as recorded version in the YouTube, the same link, through the same link. We crossed 50, sir, already.
Cross 50. We'll wait for 5 minutes and see.
To all the participants, we are just giving some more time, so people are just logging in and checking their audio, video, and things. So it's just for those who want to check their audio.
Nalini,
Mesh, we have five minutes past. You want to take up?
Yeah, I think we could begin then.
Yeah.
Good evening, everybody. Welcome back to yet another program on Telearogya series. Today we have a very interesting topic today. Does culture really matter when we're really seeing a client or when we are really managing a patient? So today we have eminent psychiatrists talking about it. And to chair today's program, we have Dr. B.R. Ravishankar Rao, who's alumnus of NIMHANS. He's passed out MD Psychiatry in 1980s. He's been a private consultant psychiatrist ever since. He's done a lot of human service and work working in this area of mental health. He's also the chairperson for Chitta Charitable Trust that runs Chittadama, the Rehabilitation and Residential Care Center for homeless persons with mental illness. He's also been an international board member of WAPR. He has been the editor of WAPR Indian chapter. He's won multiple awards, predominantly at IPSKC. We've had him receive the SS Jairam Award, Dr. LGP Achar Oration Award, and also the Eminent Psychiatrist Award. Dr. Ravishankar Rao has done a lot of work in the area of wandering persons with mental illness in the wandering category. And today he's going to chair today's program. Over to Dr. Ravishankar Rao.
thank you, Mahesh, for those nice words. Good evening, everybody. At the outset, I thank the Telearogya team of Dr. Jagdish, Dr. Mahesh, and Dr. Vijay for giving me this opportunity to chair this session. The topic for today's presentation is, does culture matter in managing our patients? We are all aware that every individual has a cultural identity, and this contributes to a cultural explanation or meaning of his illness. Culture shapes how and what psychiatric symptoms are expressed. Culture impacts the interaction between the patient and his family with the healthcare system. Culture has implications for management and prognosis. The speaker of the evening today is Dr. Raghuram, who all of you know and needs no introduction. But I still would like to introduce him, as it would serve as a background to his presentation this evening. Dr. Raghuram is a well-known teacher and researcher in the field of psychiatry. He worked for over 2 decades as professor of psychiatry at National Institute of Mental Health and Neurosciences, and subsequently went over to the United Arab Emirates to initiate a postgraduate residency program in psychiatry for the first time in that region. After completing this assignment, he was professor and head of the Department of Psychiatry at the Kempegowda Institute of Medical Sciences, Bangalore. His main interest has been in the field of cultural psychiatry, wherein he has employed anthropological approaches to examine cultural and contextual determinants of psychiatric problems. A Commonwealth fellowship facilitated this tenure at the Department of Cultural Anthropology at the University College London. And subsequently, as a WHO fellow, he worked at the Department of Culture, Community and Health Studies at the University of Toronto. He was a consultant at the International Center for the Study of Culture and Medicine at Harvard University. He was a visiting professor under the NIMHANS Fulbright Academic Initiative Program at the Department of Psychiatry, Robert Wood Johnson Medical School, New Jersey, USA, and was instrumental in initiating a cross-cultural exchange program of medical students and psychiatric residents. He has been in the board of governors of the World Association of Cultural Psychiatry for over 2 terms. In this capacity, he represented the South Asian region. He is on the advisory board of the Center for Psychotherapy and Clinical Research, Ambedkar University, New Delhi. He has over 50 research publications and chapters in books. In particular, he has been involved in examining cultural and social factors influencing the experience of stigma. He also carried out a field study exploring the impact of traditional healing methods on the severely mentally ill. Dr. Raghuram has received several awards both nationally and internationally, significant among them being the D.L.N. Murthy Rao Award, S.S. Jayaram Award, Bhagwat Award, and the Bombay Psychiatric Society Silver Jubilee Award. He was a scholar in residence at the University of Basel, Switzerland, where he was invited to give the prestigious Geigy Memorial Lecture. He is a fellow of the Royal College of Psychiatrists, UK. He is a recipient of the Eminent Psychiatrist Award of the Indian Psychiatric Society, Karnataka chapter. He is the founder and trustee of the NGO Padai, which is involved in education of the underprivileged rural children. Besides his academic achievements, Professor Raghuram is a nature enthusiast, avid bird watcher, and has an abiding interest in the visual arts. He uses his camera as a poetic tool to see nature around, and photography for him is a mindfulness, meditative practice. His abiding interest in the visual arts has drawn him to artistic creations. He is an avid bird watcher, and his blog is replete with accounts of his tryst with birds, the photographs and the narratives displaying a creative brilliance of their own. In his own words, he is besotted with murals. His eye for artistic detail is brought out in the illustrations and narratives of murals and sculptures of the Hoysala, Pallava, Vijayanagara, and Nayaka periods. I would like to conclude by quoting Dr. Raghuram himself. I feel close to God in my explorations in nature. I feel his presence in the silence of the forest. He responds to me in the chirping of birds. My hopes soar with them, with their wings, when I am overwhelmed with a sense of despondency. I seek his beauty in the brilliant hues of flowers. This is a fairly long introduction I have indulged in, but I thought it was necessary to understand the cultural identity, which we are going to hear about later in the talk today, of the clinician and teacher and polymath, Professor Raghuram, to appreciate this evening as to where the presentation is coming from. Dr. Raghuram, the screen is yours.
Thank you so much, Ravi, for your kind words of introduction. And thank you all for joining in this evening's webinar. Some of you might wonder about the title of this presentation. Does culture matter in managing our patients? This title might sound a little offbeat, if not strange. For instance, have you ever had a webinar or a seminar with a topic, does biology matter in managing our patients? We have never had. Why is it so? It is simply because we have cultivated a habit of looking at mental illnesses within the prism of biology. Undoubtedly, it has given us rich dividends. We have understood the biological underpinnings of mental illnesses in ways that our ancestor was not able to unravel. Various kinds of biological treatments have evolved over time, and they have made significant impact in the lives of people whom we take care. Yet the question remains, is man just a bunch of molecules, or is he much more than that? What we must try also to understand that it is imperative that we pay attention to the socio-cultural context and milieu in which individual suffering is enmeshed. So the task ahead of me today is to really explore the cultural landscape as it pertains to the mental health issues in our clinics and in our practice. At the outset, I must say that my interest in cultural psychiatry evolved years ago, mainly because of two teachers. One is Dr. N.C. Surya, who taught us during our undergraduate years at JIPMA, and later on, Dr. R.L. Kapoor. These were two important initiatives and inspirers who really led me on the path of exploring the cultural dimensions of psychiatric practice. Often we feel that culture is something extraneous to us. That is not very surprising, because like anything else, culture is enmeshed in a host of different perceptions. To begin with, like all other concepts, how do you define culture? And of course, there are hundreds of descriptions of culture. So let us explore, to begin with, as to what constitutes culture. What is culture? As I said, there are more than 100 definitions of what constitutes culture. But what is the core concepts that are embedded in this concept of culture? Culture is essentially values, beliefs, attitudes, and practices as they impact individual experiences and everyday life worlds of people like us. If I take this analogy further, culture is this big ocean in which, as fishes, we survive, we imbibe, and we exist. And this vast ocean is what encompasses us, it nourishes us. And we are embedded within this big ocean and derive our sustenance from that. What has happened in this vast ocean of late is that there has been an intruder who has changed our lives in ways that we never imagined before. Even the simple task of me addressing you over the Zoom was unthinkable 6 months ago. We are not able to touch each other. We have to maintain distance, and we have to communicate with each other through media like this. So our world has undergone a tremendous change due to the advent of this coronavirus. But coronavirus is a new entry in the world landscape. Pandemics have been occurring all over the world ever since history. And each pandemic has taught us some lesson or the other. The question is there an impact of culture or the role of culture in pandemics? In order to explore that, let me come closer to home, to Bangalore. In the year 1898, there was an outbreak of plague in Bangalore. A man died of plague and he arrived from Hubli. He was the butler of a railway officer. And consequently, the infection spread very widely with disastrous consequences. Thousands of people died, and many of them fled away from the city. Meanwhile, people in Bangalore started feeling that plague had come to the city because of the wrath of the Grama Devates. And many temples dedicated to Mariammas came into existence. And they were called as plague Mariammas. People had an overwhelming belief that this goddess would cure them from plague or keep them safe from contracting the disease. Plague has disappeared from Bangalore now, but even today, the belief that praying in these temples will ward off any kind of disease continues. There are many temples dedicated to plague Mariamma in Bangalore, and this is one of the notable ones, which is still in worship. This is called the Sri Plague Maheshwari Temple, which is there in Halasuru. And there is also a plague Mariamma marriage chowdhury, which is very popular in one part of Bangalore. If you start feeling that this entire thing of trying to see that invoking a goddess would try to help us to tide over this crisis of a pandemic is something tucked in the annals of history, it is not so true. Mahishasura Mardini has had a new advent. She is called as Corona Mahishi. If you look at this painting closely, you see the goddess's many hands holding sanitizer, masks, vaccination needles, and medical kits. And don't miss that the corona is held in chains and it is impaled by the trident of Corona Mahishi. The story unfolds further. There is an installation of Corona Devi in Kottayam, Kerala. Strangely and interestingly, the deity is a replica of SARS-CoV-2 with red spiky tentacles, which you can see. And the priest calls it a new addition to the pantheon of Hindu gods, and that god is omnipresent and exists even within the virus. Hence, worshipping the goddess will offer protection and relief. He even offers services through postal services. If you send a message to him, he'll pray for you and then send you the prasadams after worshipping and conducting puja to the Corona Devi. Now, these are measures that have been taken by people in order to cope up with the advent of a disease that is overwhelming them. At one level, even though centuries have passed, people are coping up with illnesses that they feel is really, they are burdened with these illnesses. They resort to these practices. So, in some ways, plague Mariamma has taken a new avatar in Corona Devi. As people try and cope up with the illnesses like this coronavirus, there are also another unsettling aspect of the viral infection. The viral infection has also necessitated that people affected with the virus face rejection, they are avoided, they are excluded, and they are ostracized. All these are components of stigma. And this stigmatizing attitude is not really confined to people who have coronavirus infection. It is also affecting people who take care of people with this infection, like the healthcare workers and doctors. So stigma has played a big role even at present in terms of people's attitude, in terms of responding to the infection. So what does this entire thing tell us about the work of culture? If you look at what has happened during plague, and if you look at what is happening during the current corona infection, what you notice is the beliefs get played out in terms of how people interpret the illness, the values of dirt, contamination, and untouchability, attitudes, that is one of rejection and stigma, and practices in terms of help-seeking behavior. So the work of culture is enacted every time a person or a community is faced with a crisis in terms of an illness. So the question is, how do we really study the work of culture in our field of interest, that is psychiatry? To begin with, culture was seen to be enacted only in exotic, non-Western locales. Kraepelin initiated the discipline of comparative psychiatry. He went over to Indonesia to study as to how culture really gets enacted in terms of influencing the symptom presentation of people with schizophrenia. And he did find differences. He noticed that there is a relative absence of delusions among Javanese, which is due to lower stage of intellectual development attained in this population as compared to the Europeans. So what you notice here is that, number one, people notice differences. But what is most unsettling is these differences are interpreted in terms of a lower stage of intellectual development in non-Western population, which itself is stigmatizing attitude towards the non-Western population. The subsequent developments were in Africa. People started studying depression in Africa. And one of the important contributors was Carruthers. Carruthers studied as to how people with depression present themselves to the psychiatrist and what are the symptom profile and belief patterns of these people. And then he noticed, like Kraepelin, there are some differences. Again, much like Kraepelin, he remarked that these people are a psychically underdeveloped population akin to immature European youth. If you feel that this particular comment has appeared in a very obscure journal, you'll be surprised. This is a statement from a WHO monograph which came in the 50s. So the prevailing perception of cultural psychiatry at that period of time really pointed out that the differences in the presentation of psychiatric illnesses is more a function of a deficient intellectual development in non-Western population. And this is the title of the monograph, which was published by the WHO in 1953. There was another pathologist who really accompanied Carruthers, and then he tried to understand the biological underpinnings of these differences. And he said, the stage of development of brain reached by the average African native is that of an European boy of 7 to 8 years. So the old cross-cultural psychiatry's focus was always on the other who's different from the Western norm. The other was always found to be an insufficient other. So old cross-cultural psychiatry really emphasized that the university of Western models of psychopathology and emphasis on cultural differences. So what was accepted was that the Western models of psychopathology are universal, and whatever differences that are found is on the basis of linguistic or intellectual underdevelopment. What we must really understand is that cultural influences are not limited to culture-bound syndromes. Culture-bound syndromes are good fodder for short notes in MD exams and nothing more. So the crucial question is, can nature and culture be unshackled from the language of differences? It is on this background that the new cross-cultural psychiatry came into existence. The new transcultural psychiatry emphasizes that psychiatry is never culture-free in whichever context it is practiced. All models of psychopathology are culturally constructed. And it emphasizes, again, not on differences, but on cultural modulation. And two important architects of new transcultural psychiatry are Arthur Kleinman and Roland Littlewood. As doctors, our focus is on disease. That is what we are trained to be. In our medical curriculum, we are encouraged to detect signs and symptoms, study the pattern of illness, understand as to how well we can really influence the course of illness through our treatment. And this is a very important element of medical practice. So disease is basically a biomedical construction. It enhances our professional understanding of the problems that patients present to us. And it is anchored in theoretical frameworks which we have as medical persons. The question is there another way of understanding people's problems? As much as configuring it as disease has helped us to alleviate their suffering, is there any other way in which you can understand their problems in order to help them further? The other perspective to understanding disease is to focus on the illness. What is an illness? Illness is patient's own understanding of the problem, in contrast to the biomedical understanding of the physician who treats the person. It incorporates subjective personal experiences of the sufferer and the meanings assigned to it by the person. And understandably, it is shaped by socio-cultural influences. So essentially, disease is a biomedical construction, and illness is the way a person with a problem tries to understand and assign meanings to it and handle it. Arthur Kleinman said it very, very eloquently. He said, the illness is embedded in a particular life trajectory, environed in a concrete life world, and acting like a sponge, illness soaks up personal and social significance from the social world of the sick person. In order to have a glimpse of it, we have to understand the work of culture. So what we have to reconcile is that disease and illness are two different interpretations of a single clinical reality. The question then is, how do we unravel the illness experiences? In order to unravel the illness experiences, we have to cast our glance beyond the obvious. How do we do that? Let me quote one of the important contributors in the field of cultural anthropology, Clifford Geertz. He wrote an interpretation in his book, Interpretation of Culture in 1973. And I quote him: "Consider two persons rapidly contracting the eyelids of their right eye. In one, it is an involuntary twitch. In the other, a conspiratorial wink. To the observer, two movements are quite identical. From observation alone, one could not tell which was a twitch and which was a wink. Yet the difference between them is as vast as anyone unfortunate enough to have had the first mistaken for the second knows." So the question that we'll have to ask is, what is different about this disease as it manifests in this patient who is sitting in front of us? So in order to understand that, Arthur Kleinman outlined the concept of explanatory model. The explanatory model consists of 8 questions. These are: what do you call your problem? What causes your problem? What do you think it started when it did? How does it work? What is going on in your body? What kind of treatment do you think is best for your problem? How has this problem affected your life? What concerns you most about this problem or the treatment? So if you ask these, if your inquiry encompasses these 8 questions, it offers you the explanatory frameworks that patients use in order to understand, cope, and act with the problem that they are experiencing. So with this explanatory model paradigm, emerged a new discipline in psychiatry called the cultural epidemiology, which employed the explanatory model paradigm in research inquiries. So incorporating the cultural epidemiological framework, myself and my associates, most importantly, Dr. Mitchell Weiss, have undertaken a bit of work to understand the cultural perceptions concerning schizophrenia. And if you look at the explanatory model that people with schizophrenia have, one of them said, this is a caregiver of a person with schizophrenia. He said, my sister developed protrusion of the uterus and suffered a lot. She was bleeding from there, and this excess blood loss must have caused weakness of her nerves. Subsequently, her uterus was also removed. I feel that her illness is due to that loss of this important organ. She stopped menstruating. Imagine a man who does not pass his 7. What would happen if all these things accumulate inside the body? I feel the same thing happened to her also. Menstruation helps in cleaning the body, and with its loss, the impurities have accumulated, causing nervous tension. My aunt also has similar kind of nervous problem. My sister was brought up by her. I wonder whether that has anything to do with her illness. If one lives close to a person with this kind of a problem, then she or he may also develop the same illness I feel. So if you look at this narrative of a person who is a principal caregiver, what does it inform us? He has used a plethora of explanatory paradigms to explain her illnesses, her illness. It could be due to blood loss, which is a biological parameter. And then he goes on to say that, if a person is stopped menstruating, things accumulate inside the body, and that can cause quite a lot of problem. Some kind of a humoral explanation. Menstruation helps in cleaning the body, and the impurities have accumulated, causing nervous tension. And there is also a genetic component. My aunt had a similar illness. And third and lastly, whether living close to somebody else would also expose yourself to the same kind of a problem. So explanatory models are not unitary. They really are comprising of a wide canvas of explanations, as this particular narrative outlines. What we must also remember is that patients hold multiple causal models, and non-medical beliefs coexist with biomedical explanations. Patients do not feel that they are in contradiction with each other. Though it may appear contradictory, it helps the patients and their caregivers to negotiate the traditional as well as the modern systems of care. And lastly, causal models function both as coping strategies in relation to illness, as also facilitators of help seeking in a pluralistic health system. See, if a person has a problem and then he starts feeling, he goes to a doctor, and the doctor gives the person some kind of medication. The medication does not really help the person to overcome the problem. He's not going to resign himself to say that I'll confine myself only to a biomedical kind of an intervention. If there is no improvement, he'll seek every possible remedy, including any kind of non-medical beliefs, in order to obtain relief. And that is essentially a human need. The other aspect that we'll have to really pay attention to is that explanatory models are not static. They change over time. And proportion of patients holding disease models increase over time as a function of treatment and its impact, which is understandable. But then, after a while, the disease model explanation tends to plateau. And explanatory models fluctuate over the course of illness in response to the severity of the illness. And patients tend to hold on to non-medical models if there is no improvement in the illness. And presence of the disease model and at least one indigenous model had a stronger impact on remission than the disease explanation per se. And this is a very interesting study by Jacob from Christian Medical College, Vellore. What about the explanatory models of community health workers? See, community health workers are key components of the National Mental Health Program. They are the ones who identify people with mental health issues, bring them for treatment, and ensure that they come regularly for follow-up and take treatment appropriately. Now, what are the explanatory models that these community health workers have in India? When they investigated key personnel in the National Mental Health Program, it was found that a significant proportion of community mental health workers did not recognize psychosis as a medical problem. They felt it was caused by black magic, evil spirits, and poverty. More importantly, they felt that doctors could not help in this condition. So if these are people who are key workers in the National Mental Health Program, in order to ensure that the interventions that mental health professionals initiate really work with the clients, we also have to really understand the explanatory models of community health workers who are involved in executing the program. Next, once we explore the explanatory models, we also attempted to study the stigma associated with schizophrenia. And not very surprisingly, we found high degree of perceived stigma, both in the patient as well as in the family members. For example, one of the family members said, "Nobody should know that our daughter is unwell. What would happen if others come to know that she has this problem? All of them will avoid us, stop visiting us at home. They will also think less of us. Who will marry her if they know that she is having this sickness?" Forget about us, doctor. Will any psychiatrist or counselor ever marry a person like our daughter? It is terrible to suffer like this. I pray to God that nobody should have this kind of an illness. This is how stigma is enacted in actual life worlds of people who have illnesses about which they have an attitude that isolates the person with the problem. If you substitute coronavirus infection for schizophrenia, much of it will ring true even now. What will happen if others know that I have coronavirus? People will avoid us. They'll stop visiting us. They will also think less of us that we have picked up this infection. So the stigma about illness, whether it is schizophrenia or coronavirus, persists. And what we found in our study was stigma was related to lag period to onset of stigma. The more the family has a stigmatizing attitude, they hesitate to take treatment early. And we all know by now in the field of psychiatry that lag period to onset of treatment is a major variable impacting the response and outcome to treatment. And stigma was also related to preferences for traditional methods of care and reluctance to access Western medical help. So when we undertook a study to assess as to what is the help-seeking behavior of patients with schizophrenia and their families, we found that even though they consulted allopathic general practitioners, the preferred mode of seeking help was visiting healing temples or going to a faith healer or opting for Ayurvedic help. Why does it happen? Again, one of the family members told us, perhaps it is our fate to have a problem like this. We take our son to various temples with hope in our hearts. And we also met a doctor once. He made fun of us and said it is purely a brain problem which medicines only can cure. But we have seen people like our son taking medicines for years. They have a dazed look and walk like machines. Perhaps the medicines might help. But what is wrong in visiting temples? What we notice in the practice of psychiatry, especially in our country, is that there is a wide divergence between the culture of psychiatry and what I would call as the culture of the laity. The culture of psychiatry, as I pointed out earlier, is strongly influenced by a biomedical framework, whereas the culture of laity is embedded in the cultural nuances through which they interpret and act on their illness. So as a consequence of this divergence, what happens is and this is something, this kind of a divergence was noticed quite long back by my teacher, Dr. Surya. He remarked in one of his writings, my basic medical training was in British India. My medical practice was in UK. When I returned to India, I was faced with Indian psychiatric practice. Many of the concepts I learned abroad seemed to make little impact. After considerable introspection within myself, I located the difficulty. I was an Indian facing Indian patients and Indian situations, but in dealing with this, I was applying totally different value systems, which are alien both to myself as well as to the patients. So what this really illustrates is what I would prefer to call it as an example of cultural dyslexia. So if there is cultural dyslexia, how do we go about addressing that? In order to address that, we have to make an effort to understand the language of the laity without prioritizing our biomedical frameworks. And as I emphasized earlier, one way of exploring the understanding of the laity is through explanatory models. And there are three major instruments that have been used in research in India. Explanatory model interview catalog, which Mitchell and myself used in many of the studies. There is also a short explanatory model interview by Jacob et al. From Vellore. And lastly, there is an explanatory model interview evolved by Patel and others. So these three major instruments can be of much use in terms of unraveling the explanatory models of our clients. So what do we do using these kind of strategies? Firstly, elicit the biomedical concept of the disease, whether they recognize it as a medical problem, and what is their expectation of the treatment process. Then explore the patient's subjective experience of illness. What are the frameworks of beliefs associated with the illness, which I alluded to as explanatory models? Then examine the social meanings of sickness, how others react and respond to the problem, through which we will analyze the social attitudes to a problem in terms of unraveling the stigma associated with the illness. And lastly, empower the person to transcend their suffering. These are the 4 E's that is very important in the practice of psychiatry, which is culturally sensitive. Most importantly, focus on narratives. To a large extent, psychiatric practice focuses on the observables. The observables in terms of what you want to elicit, in terms of phenomenology, in terms of symptoms, in terms of what kind of symptom that he has according to the text of psychopathology. That is important for us to arrive at a diagnosis. There is no doubt about it. Beyond eliciting symptoms, try and elicit the narrative. What do I mean by narratives? Narratives is patients' own understanding in their own words as to how they explain that illness. In order to do that, again, there is an instrument which is called as MINI, McGill Illness Narrative Interview, which has 46 items. Section 1 has initial illness narrative. Section 2 has prototype narrative. Section 3 has explanatory model narrative. And 4th attends to services in response to treatment. And 5th on impact on life. So what is essentially done by this instrument is, in section 1, you ask the person to really narrate in his or her own words, how do they understand their illness. In section 2, try and understand their biomedical frameworks as to what they feel is the kind of illness they might have according to the biomedical perspectives. And section 3, as I emphasized earlier, is explanatory model, what kind of beliefs that they have, and then the help-seeking behavior, and most importantly, how the illness affects their individual lives. As you unravel the narratives, we must be aware of the looping effects between symptoms and behaviors. Symptoms and behaviors evoke social responses and cultural interpretations, which in turn influence the experience and expression of symptoms and behavior. If a person is to be having paranoid symptoms, there will be certain kind of social responses attending to that. And that will be interpreted within a cultural framework, which then will influence the perception of the symptoms and behavior by the person and others. So far, I have outlined as to what is the importance of initiating a cultural mode of understanding of illnesses. I started by saying as to how the recent advent of coronavirus tells us about the work of culture. And then I pointed out as to how the work of culture can be studied with reference to psychiatric illnesses, particularly in reference to some of the work that we have done with reference to schizophrenia, and focusing on the importance of narratives in psychiatric practice. The cultural understanding is not just limited to the consulting room. I personally feel that it has very important implications in terms of what kind of research that we can undertake in Indian context. Let me give some examples. I think ethnopsychopharmacology is a very important area for research inquiry in our country. Why is it so? What we know by now is many of our patients do not really swallow the pills that we prescribe. Treatment adherence is a very big issue in all of medicines and also in the practice of psychiatry. Now, we know that the medicines that we prescribe to our patients will really impact their illnesses in very favorable way. But why do patients, are very uncomfortable about swallowing it over a period of time? As I mentioned earlier, the rates of non-adherence in schizophrenia is very significant, ranging from 24 to 88%. So the work of culture with reference to this will involve exploring the patient's belief about medications, how they are helpful, how do they act, and concepts about side effects. What we must understand also is there are a lot of ethnophysiological constructs which are operative in our culture. Most importantly, the concept of heat and cold. Medicines are classified as either increasing the heat within the body or having a cooling effect. For example, in any of our practice, moment we prescribe a medication to the patient and the family, many of them would ask the question, "Doctor, is there any dietary advice?" Why do we ask for a dietary advice? Is dietary advice important? Is dietary advice crucial for the management of the patient? Because for the patient and the family, the medicines that they swallow is not so separate from the food that they also take. So if you tell them that, in all your wisdom, you give some advice about certain kinds of diets, because patients, as I said, and their families believe that certain kind of diets might increase body heat and might adversely impact the psychological status. Sometimes they ask you, look, should I take the medicine with water? And you say, yes, you can take it with water. And then they'll say before food or after food, and then you answer them appropriately. And then the final question would come, can I take it with cold water or hot water? Now, we might dismiss it as irrational beliefs, but these are beliefs that are firmly anchored in patients' life worlds in terms of what medicine does for them and how their body reacts and responds to medicine. And that is something that we have to be sensitive enough to understand, unravel, and help the patient so that he can get the maximum benefit from the treatment that we prescribe. Let's turn our attention to stigma. As we are aware, stigma is a major barrier in delivery of mental health services, and it continues to be so. How do we unravel the work of stigma? In order to understand stigma, this is a simple prototype in terms of what are the components of stigma. There is a kind of a stereotype about mental illnesses, and that stereotype influences the division between us who are healthy and them who are unhealthy. And those who are unhealthy are assigned a low social status and discriminated, and the labeling worsens the stereotype that people already have. As I mentioned earlier, we have done a little bit of work on stigma with reference to depression, schizophrenia, and epilepsy. So this is one of the questionnaires that we have evolved. It is a short questionnaire, and which could easily be used by anybody in the clinic or in the community to understand as to what are the different ramifications of stigma. If I can read through it very quickly, you ask the patient or the family, does anyone know about this problem? Anyone whom you do not wish to know? Did you tell anyone about it? What were your reasons for telling them? How much have you told them? Do you think less of yourself because of your problem? Might contact with you have some kind of adverse effect on some people around you? If they knew about it, would your neighbors, colleagues, and others will think less of you? If they knew about it, they will think less of your family? Is there anyone in the particular whom you do not want to know about the problem? For unmarried people, if people know about it, will it affect your chances of getting married? For married patients, how will it affect your relationship with your partner? And for unmarried patient, after you get married, do you think this problem might cause trouble in your marital life? And for married patients, might this problem cause trouble of any kind in your marital relationship? And lastly, could this problem make it difficult to arrange a relative's marriage? Each item is scored on a 0 to 3 Likert scale, higher scores indicating greater degree of stigma, and we demonstrated good inter-rater reliability and internal consistency of that scale. Now, what I'm emphasizing is stigma is something that has to be explored. Unless we explore the dimensions of stigma, we cannot initiate any kind of measures to reduce the impact of stigma. As of now, we know that we feel that stigma can be reduced by psychoeducation alone. I beg to differ. Psychoeducation is one component. Unless you understand as to what are the different kind of stigmatizing beliefs and attitudes that people have and work through them, we may not be able to create a significant impact on the perception of stigma. Let's come back to COVID. I found it quite interesting in a recent article in the Indian Journal of Psychological Medicine, which assessed stigma and aggression against healthcare workers, which is occurring in a very alarming way in our cities. And what they found out was the perception of the poor that COVID-19 is the disease of the rich brought to India by international travelers is very salient. And this understandably triggers considerable angst among the poor who perceive themselves to be receiving collateral damages for the excesses of the rich. And doctors are perceived as belonging to an affluent class in India, and this may explain some of the aggression against doctors. So, as I mentioned earlier, we will have to explore the different dimensions of stigma to generate an evidence base to effectively initiate stigma reduction strategies. What I also want to emphasize is that both psychiatrists and their patients have their own explanatory models. Often there is a tendency to view patients' model as misguided, unscientific, and irrational, and be dismissive about them. This creates a huge gulf between the doctor and the patient. And there is an overwhelming gap in communication between the doctor and the patient as a consequence. How do we address that? Build partnership between the patient and the clinician through eliciting of beliefs. Eliciting of beliefs in terms of outlining their explanatory models. Avoid blaming the patient, acknowledge their concerns, and do not be dismissive about their beliefs. What we must also reckon with is that cultural beliefs are not barriers in clinical interventions. They are strategies for patients to cope, adapt, and facilitate recovery from their illness. They form a basis for empathic understanding, providing resources for effective interventions. So, inquiry into cultural dimensions of illness can provide us with important insights into the social context of suffering. I started about my talk saying, will there be a topic, does biology impact our clinical practice in any significant way? What I wish to emphasize is that biology and culture are two strands that interweave and influence each other. I would call them the double helix of psychiatry. As you're aware, the double helix is the most important substrate for all of us. So they are not two divergent perspectives. They are two strands that we can attempt to interweave so that their influences complement our understanding of the patient in order to help them effectively. One of the important contributors in the field of Leon Eisenberg said it very precisely when he remarked that the decision to seek psychiatric consultation is a request for interpretation. Patients and doctors together reconstruct the meaning of events in a shared mythopoesis. Once things fall in place, once experience and interpretation appear to coincide, and once patient has a coherent explanation which no longer leaves them the victim of the inexplicable and the uncontrollable, the symptoms are usually exorcised. Sickness is not an isolated event. It is not an unfortunate brush with nature. It is a form of communication through which nature, society, and culture speak simultaneously, and we have to listen to their voices. Let me conclude my talk by pointing out to this gentleman. This gentleman is from a small village in Mandya. In this village, when AIDS pandemic occurred, there was one person who was affected with AIDS who came back to the village. The village ostracized him, isolated them, rejected them, and had a tremendous amount of stigmatizing attitude against the person as well as the family. And this young person was a teacher in the local school. What he did was he put up small posters in the school giving information to the children about AIDS. And over a period of time, he told the children, you can convey this message to your parents, to your family, to your siblings. As in the next step, he started putting these posters in the common places in the village, and he started explaining about the infection to other members of the community so that they became aware of AIDS, what causes AIDS, and how AIDS can be handled. So information was conveyed effectively through existing community resources. But once they had this information, what did this community do? They promptly established a small shrine, you can see this here, for AIDS Amma. And once they started worshipping this AIDS Amma, and that complemented their understanding of AIDS and helped them to cope with the AIDS issue and also develop a more helpful attitude to the person afflicted with AIDS. And this temple is in existence even now. Why did I want to highlight the contribution of this gentleman? I feel that in psychiatry, we can initiate these kinds of small little measures in order to reduce the stigma associated with illnesses through our professional understanding, giving information about illness, but also understanding the community's beliefs without having a dismissive attitude and helping them to cope with this kind of issues in a way in which they feel empowered to handle an issue that they feel overwhelmed to begin with. So as I emphasized earlier, biology and culture are not two different strands. They interweave with each other, and through this interweaving process, we gain more understanding about how the community understands and responds to an illness, and that empowers us to handle the problem much more effectively. Let me conclude again with the words of N.C. Surya. What this person whom I refer to has informed us is one has to travel among one's own people before attempting to lead them. Thank you very much. And I would appreciate if there are questions. Thank you.
Thank you very much, Dr. Raghuram. I think that was a fascinating presentation. Fascinating because whatever you spoke and spoke so tellingly was something that was rooted in this culture. We have been reading and listening all through our careers about psychiatry or illnesses which are based on 19th century European philosophical contexts. You spoke about Kraepelin, you spoke about Carruthers. That was the beginning of racism till it was debunked and they said that it was not a biological construct but a social construct. Now, I think we will go to the questions. There are 4 questions listed over there. I think people should mention their names, because if you're going to have someone saying anonymous attendee, it would be difficult for people to answer anonymous people. What do you say, Dr. Raghuram? Should we take that up? Because the 2 out of 3 of them are anonymous attendees.
Yeah. See,
probably there's some reason that they are doing it.
Yeah. See, I think we can honor that, because some of those questions are not, one of those questions, for example, is not in relation to what I spoke, but it's a felt need of the person. She has said, sir, my son is having schizophrenia, he's 36-year-old. We want to make our daughter a legal guardian of our son. Please, can you guide us how to proceed for it? It is a felt need of the family. And I would address it by saying that there is a provision in the new act as to how a legal guardian can be identified and how you can ensure that your son is taken care of by your daughter. Kindly consult your psychiatrist. He'll advise you as to what is the procedure through which you can ensure that your daughter becomes a legal guardian of your son. I don't know whether she listened to it.
Should we go on to the next question? I mean, it is in front of you on the screen, so you could perhaps...
Yeah. And Mohana Narayanan, practicing counselor from Chennai. How do we make a patient understand that medical intervention is not to be replaced with temple visit healings? Is it because we medical fraternity poo-poo their beliefs? And would that be a reason why they hesitate to approach a doctor? See, we don't have to force our understanding. That is the emphasis that I made in my presentation. We don't force our understanding on our clients. And I again emphasize that medical understanding and traditional understanding are complementary to each other. So you don't have to really struggle to replace one with the other. Patients would modify their understanding and act on it according to the kind of help that they get, according to the kind of benefit that it accrues by a particular help-seeking behavior. As I mentioned, if going to a doctor doesn't give them much relief, they will go to a temple. That's what each one of many people would do. So unless that process of help-seeking is injurious and harmful, you don't have any role in trying to force an understanding. Anonymous, no health insurance company is providing health insurance for a mentally ill person, so it becomes quite burdensome for this treatment. Unfortunately, sir, this is not true. Mental illness, people with mental illness are eligible for health insurance. You kindly contact your psychiatrist and he'll provide the necessary guidelines. Dr. Samrat, MD Psychiatry resident from St. John's, what is the role or lack of vocabulary in local language to describe psychiatric symptoms and disorders? Like, for example, most symptoms described as tension, etc. Dr. Samrat, kindly do not feel that we lack vocabulary in local language. By adopting that stance, you are really replicating the understanding of Kraepelin and others, that people lack certain kind of linguistic proficiency in order to explain their symptoms. For example, the symptom when they are expressed as tension is a vocabulary. That is a vocabulary in which a person will express the problem that is occurring to him. And what is wrong in that? Mamta Shetty. Oh, sorry, I missed one.
Shalini, you wished up.
Yeah, Shalini, what are your thoughts on how the arranged marriage system fits for unmarried adult with people with mental illness? Any case vignettes? Shalini, Chennai. Unmarried system, arranged marriage system. In my personal experience, arranged marriage system can work to some extent if both families understand the total ramification of the illness. Total ramification of the illness. As of now, we know that even though schizophrenia responds well to treatment, there are continuing handicaps associated with the illness of varying degrees of severity. So like any other kind of chronic medical illness, schizophrenia also is going to be a problem that can wax and wane over a period of time. So if a person with schizophrenia, the family is keen on getting him or her married, most of the time they don't consult you and they get married and then come back. And because in our culture, the kind of concept that they have is marriage can cure mental illness. And that is anchored in quite a lot of beliefs about, the unfulfilled sexual expression of the person. So many times families take decisions on their own. If at all they consult you, it is imperative that you explain, as I outlined earlier, what are the ramifications of the illness so that they take a decision in a very informed fashion. As to how, patients who get married or patients who do not get married, patients who get married, what are the diverse rates in India? There are a lot of studies, right? And patients who are not informed about their illness, how do they cope with their illness? Again, there are a lot of illnesses. In fact, I made a presentation about marriage and mental illness, and I will share that sometime with you. Next is Mamta Shetty. As far as corona is concerned, is it stigma or fear of contracting the illness?
Dr. RR, could you just stop your screen share? You'll be on the larger screen, sir.
1 minute. Sorry, I forgot about it. 1 minute. Okay.
No, it's still not changed, sir.
I've closed it actually.
Stop screen share is what I wanted, sir.
Yeah, it stopped actually. Yeah. Okay.
Yes, thank you, sir.
That's right. Coming to Dr. Mamta Shetty's question, as far as corona is concerned, is stigma the fear of contracting the illness? Of course, it is the fear of contracting the illness, but also the consequences of contracting the illnesses. Fear is about, getting the illness from somebody else. But after that, the social consequences of having an illness which is infective, that is much more stigmatizing than the fear. And by now we have enough kind of anecdotal evidence as to how it plays out. Even today, there was a video in which a person who came from US was prohibited from entering his wife's house. He was standing outside, pleading with his wife that he should come inside, even though he had a certificate saying that he's corona negative. The wife refused to admit him. Rupam Paul, do culture provide the enough strength of avoiding stigmatizing attitude of people? Definitely it would. If, as I said, in order to unravel the work of stigma, you will have to study the various ramifications of stigma, right? I outlined as to what are the different dimensions of stigma and how in studying that would help you to reduce the stigma. And I also give at the end a practical example of a village teacher who handled stigma associated with AIDS in a small village in rural Karnataka. So there are enough methods and means by which you can really work on this aspect of stigma through cultural work. Dr. Gururaj, superb lecture as usual, sir. Isn't it time that we have a detailed cultural history in our detailed workup pro forma? Thank you, Guru. In fact, there is an initiative to incorporate in diagnostic, for example, in DSM, a kind of a cultural inquiry that is appended to the DSM manual, right? It is present actually in the new version of DSM. Kindly have a look at it. And that is something that you can incorporate in your routine clinical work. Ashok Mysore. Ashok, beyond modeling such a sensitive practice, how would you advise on formally training postgraduates in becoming sensitive to looking at cultural issues in their work? As I know, the narrative practice approach that has grown in Australia is being used by a community team in Dadra and Nagar Haveli. Absolutely, Ashok. It is the narrative framework that will really enrich our understanding about the work of culture in our patients. As I mentioned, much of the clinical interview that a psychiatrist conducts with a client is focused on eliciting diagnosis and nothing more. That seems to be the sole and important purpose of a psychiatric interview. Once you elicit symptoms according to Fisher psychopathology or Andrew Sims, and then you arrive at a diagnosis, that seems to be the end of assessing the patient. Beyond diagnosis, if you sit with the patient and really allow them to narrate their illness experiences, there is a consolidation of relationship that occurs that helps not only the patient to understand the problem better, but it also helps in consolidating the relationship between doctor and the client. See, I can add on. See, when we conducted one of the research inquiries in depression, at the end of the explanatory model interview, many of the patients felt that it was like a single session psychotherapy, in the sense that all their concerns were explored, all their doubts were clarified, all their emotional experiences were acknowledged and handled. So my feeling is even an explanatory model interview can act as a single session psychotherapy in some.
Dr. Raghuram,
Yeah.
Dilating on this, now linguistics is also a part of anthropology. And now language here becomes so important. Now, when we are talking about training of our residents, the local language becomes very important. Now, I read something about Dr. Manjunath talking about having classes in the local language for the MD residents at NIMHANS. Now, how important would this step be?
I mean, undeniably quite important. See, language is a medium of communication in which a person feels at ease. See, if a person is, as a psychiatrist with your background in English, you're going to feel comfortable with certain kind of people who speak that particular kind of language, right? Which reflects a kind of social strata in which both the client and the patient and the physician belong to. It is imperative and important that you must have linguistic skills in order to understand the experiences of patients. There are no two opinions about it.
Yeah, thank you.
Next question. Sir, I'm a junior resident. I want your opinion on this. I have seen this many times. patients get better during the AP period, continue medications, come for a few follow-up. Then some relative neighbors tell them some story about medicines being addictive or some other misconception, and our patients stop medicine and present with relapse. How do we address it beforehand? Right. See, this is what I emphasized in one section of my presentation as to how you, before you prescribe a medication, you explain to the patient that, in this way, this medication can help, but also understand what is the patient's belief about medications, what are their ideas about the side effects, what are their cultural conceptions about what the medication does to them. If you conduct that kind of an inquiry along with your prescription, that would strengthen the patient's belief that medication continuation might help me in ways in which the patient understands my own beliefs. And secondly, we must accept that even though with all good intentions that we prescribe medication for our patients, majority of them will stop medication. So we should not assign, in the sense, make them feel that they have done something they should not have done and hold them responsible and have a rejecting attitude. That's what happens most of the time in psychiatric practice. The psychiatrist starts scolding the patient. Why did you stop the medicine? Blame them for that. Patients have every right to stop the medicine, and which is what many patients with chronic illnesses will do. They want to try and experiment whether they will feel better without the medicine. So it is imperative that when they come back after stopping the medicine with a relapse, you do not start blaming the patient first. You tackle the relapse. Once the symptoms abate, you sit with them and address all their concerns and beliefs about medication, and that will ensure that they take it regularly. The next anonymous, wonderful talk, sir. What are the ways one can improve their knowledge on the prevailing local culture? I don't really understand this question, sir. What are the ways in which one can improve their knowledge on the prevailing local culture? See, the question is not the local culture. The question is how the culture is interpreted and enacted by the person sitting in front of you. So do not lose yourself in the larger ambit of local culture. Whatever culture is there is enacted in the client in front of you. So try and understand that work of culture, as I mentioned again, by exploring the explanatory model, their beliefs, attitudes, and their doubts about the illness, about the medication, and your interventions. Dr. Somshekhar Bijal, changing culture and adopting new culture, migration, acculturation is causing increased number of psychiatric illnesses, especially substance-related issues, and is indirectly causing problems in management. Sir, how to address them? See, culture always evolves. Culture is never static. So in order to say that, changing culture is posing more problems, I'm not so much in congruence with your understanding. See, whenever there is a change in culture, there is a process of acculturation that occurs. Acculturation is a function of, at one level, migration and settling in a cultural milieu that is different from the host culture. During the process of acculturation, initially, the person and the family will undergo certain kinds of issues in terms of emotional adaptation to a culture that is different. But over a period of time, they will use their resources to integrate with the local culture. In persons who are not able to accomplish that task, definitely there will be certain kinds of emotional distress. And in order to cope with that, they will take recourses to substance-related issues or feel depressed or anxious. And that is something that we'll have to handle. But in handling such issues, our focus should not be just treating the substance-related issues, but also addressing the problems in acculturation. And those problems in acculturation can be addressed by inquiring into what are the issues in the cultural milieu that they find it difficult to adapt. What is the issues that come up with integration? What are the beliefs and attitudes that come in the way of understanding the local culture and understanding the problem that they have? So the ambit of intervention in such issues has to extend beyond substance-related issues and focus on the kind of problems that a person has in terms of the acculturation process. Dr. Mohan Raj, thank you, sir, for a stimulating talk. Some of our patients take advice of certain godmen. Some godmen have odd and harmful opinion. I tell this patient to discard those opinions by presenting our narrative. Am I prejudiced or is it right? As the advice by the godmen can lead to non-adherence of treatment. Right. See, I particularly feel that we should not adopt a stance of a prescriptive attitude, in the sense when people say that, they visit some godmen and then, they get benefit or not so benefit. It is a choice of their help-seeking behavior. But if it impairs the illness and you're involved in handling that illness, you gently tell them, look, what is the role of the interventions that I'm initiating? What is the impact of the practices that your godman is in forcing you to adhere to, and how it impacts your illness? And if you detail it out, any person can choose as to which is helpful for them. See, often we underestimate our patients. They are far more aware as to what is helpful for them, what is not helpful for them. If going to a particular healer or a godman is not so helpful for them, over a period of time, they'll opt out of it and come back to you. But by the time they pay the price in terms of, exacerbation of illness. So you need to circumvent that. Initially itself, if you elicit their beliefs, if they start feeling that going to godmen and this thing would be helpful, you can really explain to them as to what is their role in the treatment of the person that you're involved with. That's why in your psychiatric assessment, we'll have to go beyond diagnosis. Once the diagnosis is over, sit with the client and elicit the explanatory models. It might take a little time. It might take 15 minutes, 20 minutes, but that is the most helpful time important time that you can spend with your clients. Rupam Paul, very fascinating talk, sir. I think spending cultural theme among the mass is not individual responsibility, it's a social responsibility. Of course, it is a social responsibility, Rupam. We are not social engineers. We are not here to spread the cultural theme among the mass. That is the role of the politician in some versions of culture. What, again, I emphasize, our particular responsibility as profession is to understand the work of culture as it is enacted within the individual. And that is our commitment and responsibility. Ruben Ben, will stigma affect malingering conventional disorder patients from Karaikal? See, conversion disorder has to be viewed within the paradigm of communication. Why do people resort to conversion or malingering? What are they trying to convey? If you go back and inquire into what is the background for that, you'll invariably find some issues within the context in which they have the conversion or malingering disorder. And that requires more attention, right? If you focus attention on malingering and start treating them as liars, then definitely there will be stigma associated with that. But on the other hand, if you look at the context in which conversion or malingering occurs and pay attention to it, you can mitigate that stigma. Ajit asks, the practice of ethnocentrism, where one dwells in the belief that one's own culture is superior to another, shapes psychopathology. This is often reinforced by a whole community. what is the best way to handle this challenge? See, to a large extent, our frames of understanding psychopathology has been influenced initially by the colonial masters and later on by the likes of DSM and the others, right? See, how do we respond to that? How do we respond that psychopathology can only be understood by frameworks that are imposed on us from outside? Let us not take a judgmental attitude about those frameworks. Those frameworks are helpful in a particular way to the clinician to arrive at a diagnosis for certain purposes, right? For certification or whatever it could be. They also tell him something tangible to hold on to. See, when you're handling a patient with psychiatric illness, with that manifold expressions of psychopathology, you want to have something tangible that you want to hold on to. And diagnosis provides that initially. But what lies beyond the tangible is the untangible or intangible, and that is the work of culture. And any practitioner who is an effective practitioner to whom people come back again and again are the persons who are culturally more sensitive to the needs of their clients. They pay attention to the cultural nuances of the client in front of them and unlearn or modify some of their understandings. So that degree of flexibility in exploring different paradigms is extremely essential for the mental health professionals. Certain kind of paradigms are helpful. We hold on to that. It doesn't mean that our view and perspective is limited only to that. If we widen that prism, we unravel much more multifarious influences which play upon the psychopathology of the person. So again, I emphasize that explanatory models offer a very simple and effective tool to explore that work of culture, which can complement our psychiatric practice. Madhavi Lata from Chennai, Corona made us understand that many things are practically possible. Many organizations thought it is difficult to make some adaptation to include the staff with disabilities. But COVID-19 broke those myths like work from home, etc. Do we need to wait for such pandemic to come and teach us these lessons, sir? As I mentioned earlier, have we learned these lessons? What are the lessons we have learned from the outbreak of plague in 1898 is being enacted in the outbreak of COVID now? People, whatever be the pandemic, who responds to the pandemic? The people in the community. And how do they respond to the pandemic? By the kind of frameworks they use in order to understand as to how I can understand and help and to overcome this kind of a problem. So whichever pandemic is there, the work of culture remains. Dr. Srinivas Bhatt, sir, most of the time patients have a stigma towards psychiatrists that they don't believe in God and their customs are not understood and not required by treating doctor. So they don't discuss with that. They do double bookkeeping. What do you say, sir? See, sorry to say that psychiatrists also do double bookkeeping, no, right? In terms of keeping the personal beliefs at bay, but relating to a person through a professional attitude. It is also kind of a double bookkeeping. The question you are raising is, when patients ask you personal questions about belief in God, how much of it you have to reveal, especially if you start feeling that the kind of things that you will say will have a helpful attitude to the customer or not so helpful attitude to the customer. So you have to play it by that nuance, right? If you start feeling that just exposing or unraveling your belief about God, and the person sitting in front of you is an atheist, the communication breaks down. But what is important is to say to the person who's atheist, who's demanding to know whether you believe in God, to assure him that there are certain kinds of beliefs that you hold on to, but those beliefs will not come in the way of responding to his beliefs and his practices. If that is assured, there is no conflict in the communication at all. But often, when the beliefs clash and the beliefs are, imposed on each other, then the issue comes in. Dr. Gururaj, which cultural characteristics has the best prognostic outcome for PWI, persons with illness? Is it Dr. Gururaj? See, there is not a particular cultural characteristic that is best prognosis. See, in terms of what you're essentially asking, are there helpful beliefs, not so helpful beliefs? How do you classify a helpful belief? A helpful belief is what a person has initially and which he modifies over a period of time as a kind of interaction between him and the doctor. See, patients might come to you with a belief that medicines may not work. The doctor prescribes medicines. Medicines have a positive effect. As a function of it, his own belief about how medicines are helpful changes. So the cultural characteristics are not static. They are the function of the interaction between the doctor and the patient, and they keep on changing over a period of time in response to the illness trajectory. If the illness is not improving, patients will use multiple explanatory paradigms, much more beyond biomedical understanding. If the patient starts improving using a particular explanatory framework, most of the time they stick onto that framework because they know as to which is helpful for them. What we must understand is that our clients are much more scientific than what we presume ourselves to be. They experiment, they explore, and then they find out what is best for them.
That is it. I think we've come to the end of our questions.
Yeah.
Are there no more questions? Dr. Raghuram, I have a question for you. You spoke about a cultural dyslexia. Now, the ICD and DSM are examples of Euro-American classificatory systems, and never have the Indian, Chinese, or the Islamic cultures been considered in any of these classification systems. Now, is there anything called international psychiatry?
That's an interesting question. See, we tend to believe that there is an international psychiatry because we want to feel international by adopting the frameworks which are imposed on us by currently the North American, because the power structure keeps changing. We are still a colonized nation. The British colonized our mindset, the Americans do it. That's one way of looking at it. But beyond that, see, in terms of practicing medical professionals, the need for a diagnosis will remain, whether it is imposed from outside or, for example, there was an attempt at Indian classificatory system by WIG, which frankly was not so very different from the international classification. So some amount of professional classification will be in place. And I don't think that we should feel very uneasy. It serves some kind of a purpose for an insurance industry certification, whatever it is. As I emphasized earlier, that need not restrict our understanding of our clients. If you start looking patients as within the framework of DSM-5 and nothing more, then there is no work of culture at all. And that is the cause for cultural dyslexia. Quite often, what I've noticed mostly in training of students is when they take a history and then they come to a diagnosis, the diagnosis is according to the DSM criteria. In fact, they ask the patient, do you sometimes feel that you cannot stay alone? Plus, like that, it is checklist kind of a approach. So they tick the boxes as to which are the criteria that they ask and patient says yes and arrive at a diagnosis. This kind of a checklist approach is a blinding process. It's a blinding process in which the person who is addressing the illness of the client is not rooted in the world of the client in which he is embedded. We cannot have a kind of a communication in which we become very rigid in holding certain kind of perspectives, oblivious to the needs and perceptions of the client. So my feeling is, it is imperative that as much as we assign importance to diagnosis, we also assign importance to a kind of a cultural inquiry initially limited to exploring the explanatory models. That itself, I personally feel, is a very empowering process for the patient, and it augments the doctor-patient relationship in very helpful ways.
Yeah, thank you. That's why I think DSM-5 has, in the section 3, they have a separate clinic,
right.
Cultural interview
formulation.
Formulation.
Yeah.
And you spoke of ethnopsychopharmacology. I think it is closely related to pharmacogenomics, because you find ethnically, say the P450 enzyme systems or the serotonin receptor and transporter, there are differences in the different ethnic groups. So we have to consider it along with the pharmacogenomics.
Yeah, definitely. And, given the genetic diversity of our country, I really don't know as to what kind of roles. For example, there is a sudden upsurge in terms of identifying as to how well a person will respond to a particular drug. And a lot of companies are marketing those tests as to whether if you prescribe a test, you'll know which antidepressant to use for. See, that kind of an approach has worked, for example, for malignancy. I have my own doubts whether that will have work in the field of psychiatry, because it might work for example, for schizophrenia. Even there, I have a lot of doubts. But for the other range of minor mental illnesses like depression, OCD, and all that, I don't know how effective this prediction of response using the genetic analysis will be helpful. But work has been initiated in that process, and people will continue to explore that. But ethnopsychopharmacology is acknowledging the role of genetics, but also acknowledging the role of culture. And both can hold. That is the double helix, as I said, on the practice of psychiatry.
Okay. And finally, one last question from me. I think there are no more questions. So I'd take the privilege of asking you one last question. COVID times, telepsychiatry times, and telepsychiatry should be delivering culturally appropriate modules, or there should be an appropriateness here, and there's always a danger of cultural differences in the patient and provider interfering with the process.
Yeah, let's look at it. And I won't use the word interfering. There is a factor that impacts the process. Moment you view it as interfering, we adopt a certain kind of a stance that it is not helpful. And that prejudices our assessment. And again, I emphasize, creates problems in communication. It is one factor that impacts. Moment you have a non-judgmental perception saying that it is not an interference in your effort to help the patient is holding certain kind of beliefs and value systems that can be vastly different from what we personally hold and what we professionally align ourselves to. Now, it is imperative that before we really start assuming that only our professional frameworks will work and nothing else, we'll have to make sure that if in order for the professional frameworks to be effective, the soil on which our professionals' frameworks are embedded has to be prepared. We cannot keep throwing the seeds unless the ground is ready. And we have to understand the ground reality. And that ground reality, I again emphasize, is the work of culture. See, we can have advanced seeds which will give you fantastic returns and things like that. But unless we understand as to what is the salinity of the soil, what are the practices adopted by the father, however potent our seeds are, it will not be very effective. You can replace seeds with our medication, right? Medications are effective. We know that it can reduce the suffering of people. But in order for them to be effective truly in terms of patients taking it, accepting it, we'll have to understand the ground on which they stand. And the ground on which they stand is replete with cultural beliefs, values, and systems. And that is a crucial element in the practice of psychiatry. It is a crucial element in any practice of medicine, but most importantly in the field of mental health. Again, if you want to reduce stigma, we keep on talking about stigma without understanding the various dimensions of stigma and to how to operationalize the understanding on the field. Right? I gave the example of this person in Mandya. I was so impressed that he used psychoeducational measures. He, tried and did not really neglect their own cultural beliefs, helped them to set up a temple, and everything fell into place. And though they started accepting the patient, and they have an enhanced understanding of the AIDS also in the process. So it can happen.
Thank you very much, Dr. Raghuram. I think we come to the end of today's presentation. And I thank Dr. Raghuram for this very informative and exciting and absolutely fascinating presentation. Thank you very much, Dr. Raghuram, and thanks to Dr. Vijay, Dr. Mahesh, and Dr. Jagdish.
Thank you.
Over
Thank
to
you
Dr.
so much.
Vijay.
Yeah, I must thank Dr. Raghuram for his enlightening and very informative, talk. It was very enlightening, definitely, and I could see a lot of audience. About more than 100, and at a given time, there were more than 90. Had logged on, and also there are quite a few numbers again in YouTube, which I won't know at this moment in time. But it was definitely a marathon one for Dr. Raghuram. Definitely, it was informative and a lot of learning has happened. We're very grateful to Dr. Raghuram and Dr. Ravi Shankar Rao. As usual, you have conducted it so, very professional way. Thank you very much. Thank you very much, Linex team, Mr. Roop Kumar and Ms. Ramya for helping us, host this program. Dr. Mahesh and Dr. Jagdish, as usual, my core coordinators. Thank you very much. Dr. Jagdish, you want to say anything, any last words? Hello? Yeah. Okay. Right.
I think Dr. Jagdish has got busy.
Yeah. Dr. Mahesh, you want to say anything?
I think it's a wonderful program. After a long time, I really got to listen to Dr. Raghuram on a topic of his passion and interest. I think it's a treat for everybody. And I think he's done wonderful justice to all the listeners here today. And there were more than 40 on the YouTube. So that speaks about it. Thank you, Dr. Ara. Thank you, Dr. Ravi Shankar Rao, for a wonderful show in the evening. We never got to understand the timing, actually. Time just flew.
Thank you, Tele Arogya, for giving us a platform to talk about it. Appreciate the opportunity given to us. Thanks a lot to all the people associated with Tele Arogya. Thanks a lot.
Thank you.
Thank you all.
Thank you.
Thank you. Good night, everybody.
Good night.
Good night.